Great. Thanks for rejoining us, everybody. And for those that may have kind of come in a little later on the first session or sort of joining us midstream for this one, I'd just like to welcome you to our 2021 Spring Summit addressing price transparency's key questions. This is our second session in a total of 4. What we're doing in each one of these is addressing a key question that we've received over the past several months with regard to the price transparency requirements. And so this second session is going to be dedicated to looking at how are these disclosed data elements being used, who's viewing them, what are they doing with them? A lot of questions really centered around this particular area. And so we'll start to dive into that, as well as kind of the strengths and limitations to the data that is being disclosed by hospitals around the country. So first off, who is accessing the data? Now, we mentioned in the last session that members of Congress issued a letter to Secretary Becerra to begin enforcement, and we have in fact seen those first letters issued to hospitals that CMS has found to be out of compliance. Given the bipartisan support for this, we do anticipate those audits and compliance enforcement efforts to continue in the days and weeks ahead. The next is media, and this is probably the one that people were honestly most concerned about. You know, what news stories were going to result from putting this information out in the public domain. And the Wall Street Journal has had several stories that they have done around the pricing transparency information. This one in particular had a shocking headline, and it's the one that I think all of us were nervous about, having this type of a headline. So how much does a C-section cost? At one hospital, anywhere from $6,241 to $60,584. And this is a sensational headline for sure. And probably for those of us that have looked at payment information or contracted rate information, it's probably maybe not too shocking that a C-section was used as opposed to another procedure that might have a much tighter distribution of payment variation. And so they have selected one that resonates with a lot of people because a lot of people have had children, obviously, and also has a great deal of clinical variation that can exist, which in turn leads to a lot of payment variation. So we'll come back to that point in just a bit, but certainly this was not an article that painted our industry in a good light and did not explore some of the explanatory reasons for potentially seeing some of that variation. And so again, we'll be exploring kind of how we defend our payment structure and our charge structure in the third session as well. We've also seen some advocacy groups. I am not a person that is big on pop culture, and so I did not watch the Oscars, but if you did, you may have seen some advertisements, some PSAs involving a group called Power to the Patients. And Miss Susan Sarandon was the voice for those advertisements. And really trying to kind of hold hospitals' feet to the fire in providing this information out to patients. It did not paint hospitals in a very positive light, that hospitals essentially are greedy and secretive in terms of the way that they structure these agreements. And, I want to not provide too much commentary on this, but in terms of a response, one of the things that I always think is really important to have in our hip pocket when we get these types of messages tossed out at us in terms of our industry being secretive or greedy, I always convey back to friends, family, other healthcare stakeholders that we should follow the margin. And one key point to recognize is if we look back, and I've been involved in the industry now for going on about 20 years, if we look across that kind of time frame, the total margin value for U.S. hospitals has really not budged materially at about 4%. When we think about a thin margin of 4% over 2 decades, and again, that's just my experience here, and it predates me, what we see is an industry that is not driven by profit-hungry, not-for-profit primarily facilities. And so I do think it's a really key point for us to be able to kind of communicate back to people to say, listen, look at the data. We are not an industry that has been hungry to profit on the backs of hurting individuals. We've tried to navigate a complex payment environment to maintain a thin margin sufficient enough to continue the care in our communities. So very, very key point. And again, I wanted to at least pause at this particular slide to provide some talking points back to you as you may be kind of encountering some of this in response to questions that you've received. The other kind of group that's been looking at this information are researchers. And, we've highlighted Health Affairs and Kaiser Family Foundation, certainly 2 groups that are known for really digging into health data in a great way. And, one of the things that they've highlighted here is, compliance levels and the complexities in terms of the data that's been provided. And so, a lot of this early research really has been centered around those compliance efforts and has been really the focus for the compliance sort of research that we've done as well and presented in that first session. Notably absent in who is accessing this data in large scale, and that's really where we want to emphasize, in large scale, are payers, hospitals, and developers. And if we think about the key groups that CMS was writing this rule for, these are the groups that they believed actually would be honing in on this information, harnessing this information, and really kind of unleashing this information to lead to payment reduction in the industry. And so far, we do not see these groups really latching onto this data and using it to materially change the payment environment today. And so the question that results from that is why? Why are these key groups that we would have expected to see really diving in on this data, why are they not latching onto it just yet? And so to help answer that question, we want to be able to explore this next phase of this conversation of how do we build a database from this disclosed data? If we want to really take action on it, we need to be able to put it into a centralized place, to be able to benchmark it, to be able to discuss its strengths, its limitations, and that database construction so far has proved to be a challenge. And so to kind of help us understand that, I'm going to invite Caitlin McLuckie to come up and discuss with us the strengths and limitations as she's been working through several large-scale analytics projects here at Cleverley Associates. So.
Hi, everyone. My name is Caitlin McLuckie, and I'm part of the consulting team here at Cleverley. And as Jamie so kindly introduced me, I'm really excited to talk to you guys about how we're going to be building database with this disclosed data and the associated challenges that come with that. So as we've already said, this is really difficult and challenging stuff to be able to aggregate this data in a consistent and succinct way. And two of the biggest challenges that we found with the machine readable data is the availability of the data as well as the consistency of it. So as you take a look at this graphic, we have kind of laid out the 4 different states of charge on here and kind of just tried to show relationally how difficult it is to gather this data for those 2 reasons. So as you'll see on the x-axis, we have the consistency of the data and the y-axis is the availability. So just you can understand this, the gross charge information we find to be very consistent with how hospitals are providing this information, as well as it's relatively has high availability, meaning most providers are putting it out there. This conversely with the payer specific negotiated charge information is a lot less consistent, meaning there's just a variety of formats as it's being put out there, and some providers are actually omitting it, meaning that it's just not available for you to be able to grab to then put into a database. So we've further kind of broken down these challenges into 4 different categories. The first is the presence and updates of this information. So that's really just referring to us being able to go out and actually find the files on these providers' websites, as well as knowing kind of how recent this information is. The second is going to be the file types and layout differences. This more refers to the architecture of the file. So column names and rows, as well as the file types itself, because we know that there are a variety of formats that are acceptable, meaning text, JSON, Excel, those kind of different formats. The third is going to be relational differences. And going back to my previous slide where we talked about consistency of data, this is more closely associated with that payer-specific negotiated charge information and the variety of formats that we have seen providers providing that payment information in. So whether it's at the HCPCS code, MSDRG, APC, or charge code, and just how we can kind of get that into a format that will allow us to compare things. And then the fourth, again, more associated with that payer-specific negotiated charge information is the payer naming differences. So as providers are kind of putting out those different plan names, it's not in a uniform way, and that's another challenge when we're talking about standardizing information so that it can go into a uniform database. Okay, so the first point that we're going to drill into is the presence and updates of information. And I've broken this out into the 3 different components that the rule encompasses regarding this information. So the first being accessibility. The rule kind of refers to that the machine readable file should be able to be accessed within 2 clicks. So I've done a little bit of a case study here with 2 example hospitals, Hospital A and Hospital B. And given screenshots of how I was able to find their machine readable file information. So as you can see with Hospital A, I have a screenshot of their kind of home screen and their ribbon at the top. And they actually have a really nice link where it says pricing transparency that I was able to just click on to then be able to find their files. However, with Hospital B, there was no kind of apparent or obvious link that I could click to get to the machine readable file. So I actually had to use their search function and just type in pricing transparency. So the second component of that rule is the naming conventions. So there is a standard name format that the rule requires, and that's your EIN number, and then the facility name and standard charges for the name of the file so that it's clearly kind of designated machine readable. So again, once I kind of found the pricing transparency section on Hospital A's website, they had a really nice link for me that said, looking for machine readable files. And while I'm no genius, that was even obvious enough for me. So I was able to click that and then easily be able to go on to the facility that I wanted to see and download their file. And they also had the correct naming convention of that EIN, facility name, and standard charge. Now for Hospital B is a little bit more cumbersome. There wasn't something obvious that said, this is the machine readable file. So you can see they actually had a list of downloads and links below, and the correct link actually ended up being the one that's labeled charge master file. So it was a little bit less obvious for me in terms of determining that, okay, this was the actual machine readable file. And then the third kind of component is that effective date. So I'm sure that many of the providers that are watching right now, you have made updates to your machine readable files just as things have been evolving. And it's important for us to know when we're creating a database, how recent is the information in our database as it's being updated. And this again is a requirement of the rule that it be indicated how effective the prices or payment information is on that file. So again, for Hospital A, once I opened up the actual Excel file that they had as their machine readable file, it was very clearly labeled with this last updated date of April 15th, 2021. However, I was not able to find this information for Hospital B at all. So you can see how just the nature of going out and finding this information, downloading the correct file, and then knowing if it's up to date can be a challenge for just step one of creating this database. So now we're going to move on to kind of our second challenge, which is the file type and layout differences. So as I said, more of kind of the architecture of the file. And obviously, when we're creating a database, we want our data to be standardized so that we're able to aggregate and compare information in an easy way. So I've kind of broken down these challenges with this in 3 different steps, and then I'm going to go through again another example of looking at machine readable files. So the first challenge is going to be the file types. There are a variety of formats that are acceptable to submit for the rule. So JSON, CSV, text, and XML are all acceptable formats. However, for example, if you're concatenating a large amount of these files into a database, you may require a little bit more of your kind of IT folks to help out with that, just because JSON would require more of a software conversion to be able to get this information into kind of a standard format for an import into a database. The second issue that we see is data types within the file itself. So for example, when we're looking at that payer negotiated charge information, we can see a variety of formats for that payment number. They can be in numeric formats, currency, or we've actually seen some folks that have put it more in a text format, where it's rather than kind of a dollar amount associated with a payment, it's more contract language that is a % of charge, kind of text free-flowing field. Obviously, that presents a lot of issues when you're talking about aggregating all of these files together and being able to come up with averages or mins and maxes to be able to benchmark against. And then the final kind of issue there is just the overall file structure. So again, there was not a lot of standardization in the rule when it came to kind of namings of columns or even the kind of number of columns that are needed to be present in this file. So just having different kind of structures then presents issues when we're talking about uploading this into a database, because it's going to be very difficult to do this in a systematic way rather than kind of manual intervention that would require manipulating the files. So I've just pulled up again 2 kind of examples here, Hospital A and Hospital B. So for Hospital A, the first point I wanted to point out here is actually, again, with the structure of the file, they included multiple tabs on their machine readable file. They had one that was separate for gross charges, and then 2 other tabs when it came to the payer specific negotiated charge information. So this is kind of a different format, which is completely acceptable. But again, you would need to know that when we're importing that information. As opposed to for Hospital B, all of their states of charge are on one tab. So you actually would need to filter by that line type, that very first column you can see there, to get to the appropriate data aggregation level when we're looking at the payer specific negotiated charge information. And then the other issue I wanted to point out was for Hospital A, all of their data is in that numeric format. So you can see when we're looking at those negotiated rates for payer A, it's just all kind of in a numeric format, which is great and easy for you then to be able to create averages and things from that. However, when you look at Hospital B, for payer B and payer C, you can see that there's variances there. Payer B is represented in kind of that dollar amount in a currency format, where payer C is using more of that contract language that I referenced earlier, where it's kind of that free-flowing text showing a % of charges. So the third kind of issue that we've seen here is what we're calling relational differences. And again, big picture, we're talking about being able to aggregate this information in mass scale, and specifically looking at payer negotiated charge reporting format. So as I kind of alluded to earlier, that payer negotiated charge reporting format can vary among facilities. We have seen facilities kind of reporting it at the MSDRG level, the APRDRG level, HCPCS, APC, as well as down to the charge code. And when we're talking about relational differences, what we're saying is whenever we can, get all this information into a database, you have to be able to kind of have a common link across the facilities to be able to benchmark your payment information against. So if a facility has disclosed their payment information for a payer at the charge code level, you're not going to be able to compare them against your facility, because obviously charge codes are not universal. You're going to need to be able to kind of marry that up in an apples to apples way at HCPCS level or something more standardized. And you can see this table on the right here that I have kind of illustrated these different ways that we have seen facilities illustrating this information. And if, for example, you had gone out and tried to gather these 5 hospitals' machine readable files, you would have great difficulty in comparing, for example, hospital A has only disclosed at the charge code level and the HCPCS level. So when we're looking at the inpatient side, we would have a tough time benchmarking them against hospital C or hospital D. So you can just see those kind of challenges that it would present there. And then the final issue here, again, more associated with that payer-specific negotiated charge information, is actually going to be the payer naming differences. So as I'm sure you're aware, many facilities are disclosing these plan names in a variety of ways. Some are using kind of a more colloquial name of, BCBS, HMO. Some are including the actual very technical plan name in there. So again, when we're thinking about high level, how are we going to be able to compare this information across many facilities? Well, you're going to have to do some payer mapping to map like plans to a higher level. And this can be a little manual because there is no standard logic for how we're naming these plans. So as you look at this graphic on the left, I have this table here just showing you an example of these plan names and kind of me attempting to map them. So again, the difficulty this presents is the manpower that would be required for you to do that, as well as the potential inaccuracy. Obviously, we know that there can be some regional plan names, and if your facility in Ohio is trying to compare to a facility in California, you just may not be as well versed in what those plan names mean to correctly kind of map them to a higher level payer bucket to then be able to conduct this analysis in an appropriate manner. So we walked through a lot of the challenges associated with creating a database, but all hope is not lost. I'm going to turn it back over to Jamie for him to talk about some potential solutions and I can overcome these challenges to be able to use this information in a meaningful way.
Great. Thank you, Caitlin. So obviously lots of challenges in terms of creating a consistent, succinct database to which we can sort of tap into to create some benchmarks. And really the two kind of primary challenges that Caitlin emphasized were the availability and then the consistency of that data. And if we can solve those two issues, we can begin to get our arms around creating a database to be able to answer really a fundamental question for hospitals, and that is, how do my payment rates compare? More than anything, probably that's the question that we have gotten most for this particular section. We'd like to be able to see, is my Blue Cross better than my neighbor's Blue Cross? Is my United better than the hospital across the street? And so with that availability and consistency of information has presented challenges to be able to help answer that particular question. But as Caitlin mentioned, all hope is not lost. So let's kind of think about some solutions around these two primary challenges. The one first on availability is just a rule that probably many of us have not been acutely aware of because it's not necessarily in our space, and that is the payer rule. So there is a payer transparency rule, much like the hospital transparency rule, that requires them to begin to display and disclose these negotiated rates. And so they also have two different file formats that have to be disclosed. One is a machine readable file, and then the other is an out-of-pocket sort of negotiated rate internet-based tool. So again, very similar in terms of structure for the hospital rule. There's this machine readable file and then a kind of more consumer-oriented disclosure. On the machine readable file, they are required to disclose three different types of files. The first is a file that will provide negotiated rates for all covered items and services between the plan or issuer and then the in-network provider. And so this is probably the file that will be most important for hospitals to take a peek at to be able to see how those rates compare. And where we have a challenge today of linking payer, on hospital A and B, they're Blue Cross because there might be some naming or mapping kind of issues. Here, presumably, you could take Blue Cross's plan or United's plan and look across hospitals because it's going to be structured the same way. Again, presumably, these payers will present their information consistently across all providers. So that will give the ability to kind of solve some of those kind of availability and also kind of payer mapping issues. They'll also be presenting historical payments to and billed charges from out-of-network providers. This obviously has some elements in here that can be concerning. It can also tie into the No Surprise Billing Act. And so some of those things can be at play here certainly as well. The third will be the in-network negotiated rates for historical net prices for prescription drugs. So certainly an area that has high consumer interest and will be presenting information with that regard. All of that will come online January 1st of 2022, and that information will be updated each month. So if we think about the burden that we have to update our files each year, this is much more robust in terms of the offering and presenting obviously more current information as well. They do also have a consumer-oriented tool that might not lend itself as well, obviously, to creating a database, but will be interesting to view for sure. With that, we also, though, want to be able to look at the hospital-provided data and see if there is a way that we can view that information in a more consistent way. And so the way that we've addressed this as a company is to create a standardized payer-specific negotiated charge display. And I want to kind of spend just a couple minutes on this because it is different from the ways that that others have approached this. And we think that it has several key benefits for consideration. The first question that always comes up with this, though, is this approach compliant? And we have been leaning on some language in the rule and have actually shared this particular disclosure with the CMS pricing transparency team. And this is the language that we're using to support this. The rule says that hospitals should, quote, consult their rate sheets or rate tables within which the payer-specific negotiated charges are often found and display the individualized items and services and service packages for a specific payer's plan based on the rate sheet derived from the hospital's contract with the payer. So in practice, what the hospital is doing in this display is they are deriving that payer-specific negotiated charge by consulting their contracted rates and rate sheets and terms and applying those to actual patient claims for the specific third-party payer. So what we are able to do here is do a detailed modeling of the contracts, applying those current contracted terms. So this is not historical reimbursement, which we know the rule speaks to, but is actually doing a prospective modeling of these contracted terms and rates and applying those to patient claims and determining then what the average payment you could consider would be for those claims across all claims for a specific service category. So you can see the display here for a select number of DRGs, and then also on the outpatient side, APCs. And the outpatient side is really the very powerful kind of piece in all of this because there's been a challenge historically at grouping outpatient claims together. And we've created a methodology by which we're grouping outpatient claims by their primary HCPCS code on the claim that has the highest CPT code weight. What this has enabled us to do is to really kind of create a lot of wins for everybody. We believe this presents a better patient understanding of the total encounter payment. If we think about kind of a detailed rate view where consumer or even a developer, we're looking at all of the individualized fee schedules, carve-out definitions, hierarchy methodologies, and understanding how any of that is going to tie into a specific payment for a patient encounter. It's nearly impossible to do that without having kind of claims data to be able to kind of work through the math and understand how this will tie in to total patient payment as a result of those contract terms. The other is kind of presenting kind of relevant information to the payment, as kind of contract terms, again, that are going to be less meaningful for them. It does meet the letter of the law, and that all items and services are covered with this approach, so including drugs and supplies. With this, we can actually do payment comparison across payers. So you could see how your payment rates in total do compare with others. It does provide kind of some custom contract definitions, hierarchies, all of that factors into this display. But it does also protect the hospital in terms of this very sensitive display of detailed rates and terms. So a lot of hospitals have kind of really rallied around this approach because it provides more meaningful information. It really is in keeping not only with the rule's specific language, but also kind of in the spirit of the rule to provide that meaningful information to patients. And then also, again, hospitals have kind of appreciated the fact that those very sensitive kind of rates and terms are less visible to folks that may actually sort of use it against them or might use it in a situation to litigate against them, as some of those contracts actually have language that protects those rates and terms. So again, really feeling like this is a win for everybody included. The way that we kind of build this out just quickly is to model in all of the contract rates and terms in detail, applying those rates and terms to all items and services on patient claims, and determining an expected payment, not an actual reimbursement or a historic reimbursement level, but an expected payment for each claim based on the current contracts that are in place. And then running each of those claims through a grouper on the inpatient outpatient side to define which category that claim would be categorized into, and then deriving a median expected payment for all items and services by primary DRG or APC, and then also by payer. And then just building the disclosure that way to provide that information for the public to consume. With that, we can begin then to answer the question that hospitals have been asking, and that is, how do my rates compare? Now we can take these like structures by DRG and by APC on the outpatient side, and we can present your payment in relation to regional medians, national medians, so that you can see how your payment is materially the same or different than peers. And we can even solve that very tricky question of payer-specific mapping kind of constraints, where in the disclosures today, it's very challenging to determine how one facility is disclosing one particular payer based on its naming convention versus another. Because we have the payer mapping available to us, we can actually look at, here is your Aetna compared to a regional or national Aetna. Here is your Blue Cross compared to a regional or national Blue Cross. And the last thing I want to do on this slide is come back to that Wall Street Journal article. And you're going to notice what we find across the national average for these 5 major plans for a C-section versus a typical delivery. So it's those top 2 lines. If you look at the national median payment per discharge in those kind of greenish blue columns and rows, you're going to see for C-section DRG 788 that there is significant variation there in terms of payment per encounter. However, when you look at a typical delivery, you see a much tighter distribution here. And one of the things that we recognize, again, dealing with this data, much like you do day in and day out, is there are certain DRGs where we have more clinical variation, and we also may have very intentional contract negotiation strategies where you may give on a certain DRG or payment for a certain DRG because a certain payer provides much more volume in a certain situation than another. Or you may create a situation where you're taking more of a loss on one particular encounter to actually have more kind of net revenue coming through another for that particular contract. Again, all coming to the same overall margin level for that particular contract. So again, we recognize the complexities and why there are different payment rates established for different case encounters. These views allow you to be able to kind of evaluate your contract in total, but also at a more micro level by DRG and by APC, which can certainly be helpful, not only to get out in front of these comparisons or viewpoints before they become public, but also to be able to mitigate for some of those differences or to kind of impact strategy going forward. So with that, we conclude kind of this session on, how is this data being used and how can it be used, overcoming some of the inherent challenges that might exist today, given the current disclosure requirements. Given some of this variation and given what we recognize about our charge positions, that they've been established over many years, dependent upon many different operating factors that can be considered, what we want to be able to do is provide a way for you to defend your position as more of this information is made public. So with that, we will be taking a break for, again, about 15 minutes, and then we'll circle back, and Scott Hauk and Courtney Vance will be leading our next discussion to address this third question. So again, thanks for hanging on with us, and we'll look forward to seeing you back here in about 15 minutes.